Now let's turn to Dr. Mandana Khalili, who's a professor of medicine at the University of California, San Francisco. She's chief of clinical hepatology and director of clinical and translational research in hepatology at UCSF and San Francisco General Hospital. And she co-directs the UCSF T32 training in hepatology. And she's focused a great deal of her work on addressing health disparities related to hepatitis B and hepatitis C. And that's why she's here today to talk about hepatitis C and the homeless in the San Francisco area. Mandana?
Thank you, John, for that kind introduction. And I'd like to thank the organizers for their invitation to present at this very important forum. I am going to share my screen with you. Hopefully we can make this happen. There we go. Is it, sorry, doesn't look like it. Oh, there we go. It's a portion that's presenting, huh?
Yes, yes, that's what we're saying. Lindsay, do you want to go to our version?
Or just 1 second.
Just to, if that's okay.
Thank you very much. I really appreciate it. Yes.
Yeah. See if we can get that corrected quickly.
Thank you. Hey, great. Thank you again. Okay, so if you don't mind, next slide, please. Great. Okay, as it's been mentioned already earlier, that individuals experiencing homelessness and marginally housed individuals have high prevalence of hepatitis C infection compared to the general population. And this has been documented at about 10 to 50% in the United States, but in San Francisco specifically, where I reside, the prevalence of hepatitis C is estimated on the higher end of that range at 46%. The primary risk factors here include injection drug use, there's history of incarceration, mental illness, and also other type of barriers and complications that limit access to healthcare system. Treatment initiation is also low due to many barriers, but studies show that racial ethnic minorities, those with substance use problems, Medicaid insurance, access issues are less likely to initiate treatment, and we know that this is exacerbated in the setting of homelessness. And the data on these barriers are more limited. To improve HCV in care in the homeless shelters, there's therefore a need for targeted education programs. There's point of care testing, treatment, and identifying potential barriers to successful implementation of HCV care models. And so we embarked on our journey here. Next slide. We then I have addressed these issues across a spectrum of healthcare services. In addition to San Francisco, we engaged in partnership with a group of investigators that were interested in enhancing hepatitis C screening and treatment among individuals experiencing homelessness in another U.S. region. This was Hennepin Healthcare System in Minneapolis, Minnesota. We also engaged our local community efforts, including the San Francisco's End Hep C campaign, which is the multi-sector collective impact initiative that uses evidence-based practices, community wisdoms, and leverages already existing resources to eliminate hepatitis C within within the San Francisco Bay Area. And we wanted to make sure that these processes that are being implemented are applicable to geographically diverse regions and populations, and within the communities that efforts that already are existing. So we try to better understand the perspectives of stakeholders to ensure that hepatitis C testing and treatment processes that we wanted to implement within the context of persons experiencing homelessness are feasible, that they met the needs of those individuals, and that they could be scalable. So we did this by first conducting focus groups with individuals accessing homeless shelters and evaluated their barriers and facilitators to hepatitis C care. We then did a comprehensive assessment of potential factors that could influence the integration of hepatitis C services in the homeless shelters themselves. And we use all of this information to design an effective universal Hep C rapid testing and linkage to care model in hepatitis C shelters. And I'll share this data with you next. Next slide. To evaluate our shelter client perspectives, we did 2 focus groups involving 10 women and 10 men accessing large homeless shelters within the San Francisco area. This focus group was a semi-structured interview format. We asked about individual program systems, so societal level barriers, and facilitators to implementing universal hepatitis C testing and linkage to care. Next slide. We identified some key barriers to hepatitis C testing and treatment at the individual level. These included limited knowledge and misconceptions about hepatitis C infection, mistrust of the healthcare system, comorbid conditions that existed, such as substance use, psychiatric, chronic medical conditions. Some system level barriers included limited advocacy for HCV services by shelter staff. Individuals highlighted some societal level barriers, including stigma that exists surrounding homelessness, and individual system and societal facilitators that we identified from the participants included internal motivation to address hepatitis C treatment, financial incentives to engage in hepatitis C care, having had prior experiences with rapid HCV testing, and also availability of affordable treatment for hepatitis C. But most importantly, we found that there was an overwhelming support from shelter clients about receipt of HCV treatment if needed. Next slide, please. We then went ahead and did 4 focus groups with homeless shelter staff, practice providers, and social service outreach workers in San Francisco, California, as well as Minneapolis, Minnesota. We asked for their perspective towards establishing this universal testing and treatment within the context of the shelters, and asked the same type of questions, key barriers and facilitators from these individuals. We found that despite many barriers that were listed, that there was, again, an overwhelming broad support from these stakeholders for integration of hepatitis C services within the shelter setting across the 2 cities. Next slide, please. So let's talk a little bit about some of these barriers and facilitators that we identified. With respect to the societal level barriers, the stakeholders, now these are not individuals who are accessing the shelters, rather the shelter leadership, along with providers and other individuals engaged, included the issue of insurance, high out-of-pocket expenses, restrictions of access to Hep C treatment due to active drug use or alcohol use, excessive paperwork that was required for hepatitis C authorization forms from the payers. From a system level perspective, there was workforce constraints and limited healthcare infrastructure. There was mention of hepatitis C stigma and low knowledge of HCV treatment among the staff, and existing shelter policies that may prevent potentially implementation of these processes within the shelters. At an individual level, there were mention of client barriers such as competing priorities, the behavioral health concerns, there were health attitudes, but also some important facilitators that we identified was that there were high acceptability and buy-in for this process. And that we also identified linkage with social service providers as being critically important. Next slide, please. So what were some of the recommendations that were brought forth to us? we received these following recommendations. Offer the shortest possible course of hepatitis C treatment, establish a designated hepatitis C coordinator to really address the needs of the clients in a holistic way, use incentives to engage the patients, provide extended shelter stay during the treatment so that there won't be disruptions of housing and stability at those times, educate shelter staff, offer peer navigation and support, and importantly, provide formal hepatitis C education to shelter clients to enhance their engagement. Next slide, please. To summarize, we learned the importance of enhancing knowledge of hepatitis C, harm reduction among shelter clients. We identified various barriers to address, and we learned that providers and shelter clients agreed that patients experiencing homelessness are concerned about their health, and that scaling up hepatitis C services was important in the homeless shelters themselves. So we focused on formatting a multi-agency partnership, for example, partnering with the Department of Public Health in San Francisco to get point-of-care testing, as well as the, as mentioned earlier, community efforts, including the Hepatitis C-Free campaign in San Francisco. We partnered with existing services, health services for the persons experiencing homelessness, including street medicine teams, and in this city and in Minnesota with the shelter clinic and providers. We also identified co-localization of hepatitis C services within the shelter and implemented a formal patient education to improve client knowledge. So this led to the following model of care in two different settings, as mentioned, San Francisco and Minneapolis, among 4 large homeless shelters where we provided shelter-based point-of-care testing for hepatitis C by either shelter medical staff or street medicine team. Those who were negative were given information on hepatitis C and its mode of transmission, and those who tested positive by point-of-care testing had a confirmatory Hep C RNA testing, and then underwent to standardize a 30-minute Hep C education program. This in-person comprehensive education program was delivered by a designated Hep C nurse or a pharmacist or an advanced practice provider within the context of the shelter. The standard of care HCV therapy was offered to all participants with detection of HCV RNA through insurance or patient assistance programs for HCV by prescribing provider. We had the treatment primarily delivered on site at the shelter or through coordination with the primary care providers or liver specialty providers, if such patients chose to or were engaged through specialty care or addiction services. The treatment plan was made at the discretion of the treating provider and in accordance with what the insurance allowed. The medication dispensation, because of this, varied, and it ranged from either direct observed therapy, for example, within addiction services, to weekly or monthly dispensing within the shelter themselves. If needed, the study team assisted participants in obtaining insurance and also facilitated linkage to primary care services. So in San Francisco, we had a designated Hep C registered nurse coordinator that was actually a member of the street medicine team to begin with, and we did this strategically to ensure that there is sustainability of these efforts. She gained knowledge on treatment within the shelters in collaboration with the shelter providers and primary care providers, or the safety net liver specialty clinic if needed, where the cases may have been a little bit more complicated. In Minneapolis, a doctor of pharmacy that was embedded within the shelter clinics managed patients on treatment in collaboration with the shelter clinic staff. And Minneapolis safety net liver specialty care was also available should linkages be needed. We followed the patients throughout the treatment, completed blood tests at the end of the treatment to document sustained virologic responses. And we obtained as much clinical information as possible and asked questions about patients' knowledge and and risk factors, et cetera, to ensure that our efforts were effective. And we paid patients or individuals a $25 incentive to get tested for hepatitis C and $75 at the end of the education and also at the end of the completion of their hepatitis C treatment. Next slide. So from August 1st of 2018 to January 30th of 2021, we engaged all individuals who were willing to participate that were either treatment naive or had not received hepatitis C treatment within the prior 3 months. Our recruitment strategy was through advertisements of availability of testing and treatment within the shelter, as well as directly approaching clients. We approached about 1,199 shelter clients. Of these, 766 participated. A total of 120 individuals, 120 HCV testing sessions were conducted in overall 72 in San Francisco and 49 in Minneapolis. And of the 766 individuals who participated, 162, so 21% tested positive for hepatitis C antibody. Of these, 66% had detectable HCV RNA, so about 2/3 had active viremia. Overall, 2/3 of these individuals were male. About half were African American, but HCV positive patients had a higher proportion of white population. We had 52% overall that had been tested for hepatitis C in the past, and nearly 80% among HCV positive patients. And again, this was due to a significant amount of effort that had been previously implemented within the city of San Francisco. And it's expected a higher proportion of hepatitis C patients used drugs in the past, and this was at about 2/3 compared to 13% of those who were HCV negative. Next slide. With respect to our education program, we did this through a group education of up to 10 participants. If needed, we also provided individual education sessions, but predominantly it was performed through group education. The content of this education session was pretty comprehensive. We gave information about hepatitis C epidemiology, its transmission, its diagnosis, its natural history, the treatment options, all the information related to liver health, including vaccinations for hepatitis A and B, and resources for substance use disorder therapy were also provided, as well as syringe access services and linkage to liver disease care as needed. We made also every effort to make these education programs sort of tailored towards the perceived barriers and misconceptions that came up over and over again among the population. We found that our rate of acceptance of hepatitis C therapy significantly increased following education. It went from 71% to 86%. The confidence in methods to prevent hepatitis C transmission also increased. And overall, we noted that participants indicated that their effect of hepatitis C on their general health was significant, and that information or that percentage also increased. Next slide. So what are our results? Well, we were able to engage 62% of the patients who were eligible to receive hepatitis C treatment, which was, again, those who were viremic in treatment. We were able to achieve 82% cure rates in this difficult to reach population. And this is despite reported medication adherence that by providers were pretty low at about 50%, and by patients it was higher at about 88%. So there was some definitely evidence of lack of full medication adherence, but we were able to achieve such high sustained virologic response rates. The most prescribed treatments were, again, those that were allowed, and they were either 8 weeks or 12 weeks per the availability of the drugs through either government-based insurance or through patient assistance programs. Next slide. I wanted to highlight one additional important thing that is critical that we learned actually. We tried to better understand the severity of liver disease among the patients who were hepatitis C positive and were accessing shelter services. And about 18% of the patients that we came across had evidence of cirrhosis. I want to highlight that we identified patients who had even decompensation of liver disease, and 3% of our patients had evidence of liver cancer, hepatocellular carcinoma. Another 17%, when we look through with other various means, such as serology, or if they've had a biopsy or imaging or any kind of hepatitis C evaluations in the past, having more advanced disease. So overall, I'd say about 46% of these individuals who were hepatitis C positive within our shelters had evidence of advanced scarring or fibrosis or cirrhosis, which really highlights the importance of engaging this population in hepatitis C treatment and the critical importance of focusing on this population for hepatitis C elimination efforts. Next slide. Okay, so I think our integrated model of on-site hepatitis C treatment, testing, and education, following extensive needs assessment, including stakeholder perspective, was successful in enhancing hepatitis C services and linkage to hepatitis C therapy. And our studies sort of demonstrated tailored models of care that reduce barriers to patient engagement, including co-localization of hepatitis C care within the shelters or supportive housing, and simplified steps to Hep C treatment are critical for hepatitis C elimination efforts in this vulnerable population. I will say that following our implementation of these processing, several other initiatives have certainly been implemented, including mobile hepatitis C treatment testing and treatment through mobile vans in San Francisco, ECHO implementation, which is a sort of distant engagement of a provider in order to ensure that we have expansion of treatment services and providers who are managing patients with hepatitis C as well. And also we have extensive engagement of primary care providers within the safety net services as well in addressing hepatitis C treatment. Next slide. Thank you again for this opportunity, and I'm happy to address questions.